Yeah, so when you approach neuroendocrine cancers, it's very nuanced, and you have to have kind of a general framework to work with. And so what I focused on within the discussion was the site that the disease starts, the stage of the disease. We talked about genomics. Genomics don't play as big a role with the more common neuroendocrine tumors that we see, like the small bowel neuroendocrine tumors. However, for pancreatic neuroendocrine tumors, they do have significance. Similarly, for high-grade neuroendocrine cancers, doing genomic profiling can be, significant and impactful for patients. One of the focuses of the discussion was on theranostics, and theranostics is this kind of field of medicine where you're able to exploit some aspect of the cell, usually an antigen or a protein on the cell surface, where you can design both diagnostic imaging to target that and kind of illuminate the area. And then you could also direct therapies against that same protein or antigen. So within neuroendocrine cancers, there's a receptor that's very well known, somatostatin receptor. And so we really exploit that receptor with therapies, diagnostics. So there's a lot of focus on that within the talk. And then lastly, the one thing that I touched on was blood-based biomarkers. And I kind of caution the audience on chromogranin A not being a very good biomarker. The sensitivity is very low for that test. And then there's some evolving biomarkers that we talked about, one called a NET test, kind of a genomic signature that looks at RNA. And then also we talked about a test that can help predict benefit to a therapy called Lutathera, which is along that theme of theranostics. That's the therapy part of it. ctDNA in neuroendocrine cancers is not really a mainstream approach. And the reason for it is, as I alluded to, for small bowel neuroendocrine tumors, for example, we usually don't find many genetic abnormalities on the liquid biopsy. It'll sometimes come back within that panel. You won't find any mutations in those genes. So I think that there's a limited utility for ctDNA for well-differentiated neuroendocrine tumors. Now, that's different actually for high-grade neuroendocrine cancers, like grade 3 neuroendocrine tumors, or even more specifically, neuroendocrine carcinoma. I presented a slide within the presentation, which is a study I was a part of, where we looked at, I think, 320 samples from patients with neuroendocrine cancers. And the majority of the time when we got a signal or a hit, if you will, it was a neuroendocrine carcinoma. So I think there is utility with neuroendocrine carcinoma of using a blood-based assay like ctDNA. The problem is there's not really many targeted, we don't often find a target even within neuroendocrine carcinoma. Now, alternatively, MRD, which is molecular residual disease, that is within the realm or within the same verbiage of ctDNA. Now, molecular residual disease can follow the patient's disease at a molecular level within the blood, right? And you can follow it in terms of you have a certain starting point, you start a therapy, it goes down, you follow that longitudinally, and if it starts going up, it may suggest that progression of disease is on the horizon, or you may be seeing that on the scans. The problem with that is, even in other diseases with ctDNA, it's really prognostic and not necessarily predictive. So that test isn't going to predict that a therapy is going to work or not work. It just tells you that it is working and then it's not working, or the patient's having progression. So we're still learning how to incorporate ctDNA technology for neuroendocrine cancers. I would stress to the audience that for high-grade neuroendocrine carcinoma, or even grade or even grade 3 neuroendocrine tumors, including small bowel or pancreas, that it makes sense because those are maybe more genomically enriched patients in terms of the DNA mutations.
The current status of imaging in cancer is still very archaic. We still use technologies that have been developed in the 1980s and 90s. And we haven't really evolved in terms of how we use these informations to develop newer techniques that we can use to, understand the patient's tumor more dynamically and be able to have more informed treatment decisions. There's several new AI tools that can actually help us quantitatively and qualitatively evaluate tumor responses and define the tumor architecture much better that we haven't yet been able to deploy in the clinical space yet. But there are a lot of interesting approaches that are being tested, and I'm very hopeful that some of these will be used more routinely in tumor board multidisciplinary setting. So some of these subvisual patterns and capabilities of AI computer vision to be able to better diagnose lung nodules especially is very critical. In fact, the risk of false positives in lung cancer screening is a major barrier for lung cancer screening uptake across the country. So I think if you can address that with tools such as AI computer vision and embed that into the clinical workflow of lung nodule management, I think that's going to be a huge impact in terms of lung cancer screening uptake across the country. So there are significant and substantial gaps in terms of lung cancer uptake in United States. Despite of very clear guidelines in terms of the populations at high risk for lung cancer screening, and our uptake across the country is close to 10 to 15%. Compared to other tumors like breast cancer and colon cancer, where the screening rates are much, much better. So this has been a major barrier in terms of realizing the impact of lung cancer screening, as demonstrated by the NLST and Nelson trials, where there's about 20-25% reduction in mortality with lung cancer screening in high-risk populations. So there are a lot of opportunities to improve this, and as you know, primary care is the gateway for all lung cancer screening, or for that matter, any cancer screening. So we have to educate primary care providers about the need and importance of lung cancer screening, and also help assist them in terms of trying to find the high-risk population based on various approaches like AI-based EHR chart reviews to be able to flag patients who would be high risk for lung cancer screening.
Depends, the flow of the patient. So in the community, the flow is a little bit different than in academic center. In academic center, the patient tend to be referred early to medical oncologist, and then we have multidisciplinary approach. So what is important to say, I think the earlier you start ordering the testing, it's better. So we tend to order the germline testing, add somatic at the same time. However, there is some consequence in ordering germline testing, mostly if patient is potential for that they're not anymore be able to have life insurance or things like that. So even though I discuss German testing with the patient immediately, they don't always agree to do it immediately. They want to talk to family, make decision. In terms of somatic testing, that's something I ordered immediately if somebody is diagnosed with advanced prostate cancer. With their localized disease, it's unlikely somatic testing to happen immediately. The germline testing, for sure, we discuss and then decide, depends when patient is ready to order it. Every treatment option has some side effects, so I think monitoring the side effects are really important. It really depends on the comfort level of the treating physician and collaboration. So as a medical oncologist, I don't deliver Radioligand myself because I don't have a license, so you work closely with your nuclear medicine specialist or radiation oncologist, and then you just have to have agreement who is monitoring what. So we do frequent blood work, we do evaluation in the clinic, we assessing the symptoms, but I think the problem is when you have several people working together, you need to know who is in charge of what. And I think this is important that you know, because one can assume, oh, the other person will assess the patient, so it's kind of, it's like a teamwork. So you really need to know, okay, who is doing what and what are your responsibility, what you're supposed to do. But I think, frequently seeing the patient, doing the blood work, examining the patient, talking to the patient, then you can do adjustments as needed. It's very important. So I think it's, radioligand therapy is important tool we have in our toolbox to fight the prostate cancer. So I think what we are learning more that we are still learning who are the patients who are going to have the most benefit from the radioligand therapy. What I can say from my experience so far, it seems that it's really difficult to predict who's going to have the best responder to treatment. People respond, some of them have durable responses, some of them progress as soon as you stop the treatment. So I think learning more as we go with the treatment and learning more about the sequencing, like somatic profiling, what will help us with that. So I think there is a room for all the treatment, and we have to find what is the best sequence and how to do it. And of course, there's a cumulative toxicity. So as we go with that treatment, there is a potential that we may impair the bone marrow of the patient, and then patient may not be fit for the next line of therapy or chemotherapy. So I think since the radioligand therapy is moving earlier, I still think we have to learn about long-term toxicity because, with the initial approval was a patient who are like running out of option. They were kind of last resort, and those patients unfortunately did not live long enough to show all the side effects. So I think we are still learning as we go through this. One thing I would like to emphasize is that, clinical trial patients are your best patient. In reality, only 10% of my clinic patient will be fit for a clinical study. So 90% of my patients, they are very old, poor performance status, different comorbidities that your real world practice never represent the data you see in the clinical trial. So I think as we are using drugs more, I think we're all learning, and hopefully in the future we'll have better understanding and better sequence and decide what goes first, what goes second.